prepuce or mild ballooning of prepuce, really none of these are indications for circumcision. So we will now say that what is pathological phimosis in children? And pathological phimosis is when there is a fibrosis here, over here, there is scarring and thickening of this foreskin. That is pathological phimosis, and that will have to be treated either by a circumcision or a prepucioplasty, depending on whatever the choice. So this is going to be the picture here. You can compare this with the previous picture, which I have just shown you, that this is a different picture. And in severe cases, you will see this whiteness also. And that is severe scarring is there. So these are the patients who definitely require surgery for the phimosis, but not the other ones which I had shown you earlier. Coming to the next condition, that is a hydrocele. Well, you all know the definition. It's a collection of clear fluid in the scrotal sac. Now, when you see a small child with a hydrocele like this, very often these are temporary, these are physiological, especially in newborns and early infancies, because these are not communicating hydroceles. These are not what we call a persistent processus vaginalis. It's mainly because of the immaturity of the lymphatics, of the scrotal lymphatics. That's why this fluid is not getting drained adequately. And invariably, by about 6 months of age, these hydroceles subside and disappear. So these don't really require surgery. Surgery is required only if there's a hernia. If these hydroceles persist beyond the 1 year of age, then possibly surgery may be required. Or if you can establish that these are communicating hydroceles, that means there's a patent processus vaginalis, then you will need to operate these patients. Coming to the next common conditions, and that is inguinal hernia. Here, there is very little doubt. Inguinal hernias have a very high propensity for strangulation. You can see this particular child, a small child who has got a red scrotum, completely swollen over here. So this is a strangulated hernia. And unfortunately, the smaller the child, the higher the chances and the worse the morbidity of complications in case there are complications. So the smaller the child, the higher the chances of strangulation. So that is unfortunate, but that's a fact. And here you will see that in such cases, this particular child, you can see there's complete gangrene of this intestine. And obviously, it has its great significant morbidity. So for a hernia, always surgery and as early as possible. So here there is no doubt about it. Hydrocele, we wait. For a hernia, we will not wait. For an inguinal hernia, because delay can be harmful to the child. Coming to the next variety of cases, and that's the umbilical hernia. Here, again, confusion whether to operate or not to operate. Well, the fact is that most umbilical hernias resolve by about 2 years of age. Some of them may take a little longer, but at least latest by 5 years, almost all of them resolve. So they will resolve on their own without doing anything else. But one has to keep in mind that umbilical hernias can also get strangulated. They can also have all the complications what a strangulated inguinal hernia can have. So this is something which one needs to keep in mind. And in case they get strangulated, of course, you will need to operate them early also. So what are the indications for surgery besides strangulation in an umbilical hernia? If there is a history suggestive of strangulation at any age, these are the patients who are likely to get a strangulation again. And please, so even if the strangulation has subsided, please operate this patient early because he is going to get a strangulation again. If large hernia are present beyond 2 years of age, that would be a relative indication for surgery. But any hernia which is persistent, umbilical hernia persistent beyond 5 years of age, definitely requires surgery. So these will be the indications for this thing. In addition, there are certain connective tissue disorders like Hurler syndrome and all. These are the patients who are not going to settle without surgery. So this is a child with a Hurler syndrome, and this child will be needing surgery irrespective of the fact that it's an umbilical hernia, and even if he comes to you at earlier age of 1 or 2 years. But these are rare conditions, very rare. Coming to the next one is retractile testis. Here I'm going to use this particular term because to include all those patients where you see an empty scrotum. So retractile testis is basically a physiological condition. it is because of an exaggerated cremasteric reflex, which reduces by age. And if you examine these patients, testes can be milked to the bottom of the scrotum. However, please don't expect the sonologist to differentiate this, because in the sonography room, because of the cold temperature, the testis invariably goes up again, and that again becomes retractile. So it is not an undescended, and they pick it up as an ectopic or an undescended testis. So the decision whether it's a retractile testis or an undescended testis is going to be a clinical decision and not a sonography decision. So here you can see that this is testis, which is good. So the scrotum is reasonably well developed. In a retractile testis, you will see that the scrotum is reasonably well developed as compared to the undescended testis, where you see a bilateral undescended testis, you see a flat scrotum. So this is a patient where the undescended testis and it's a flat scrotum, but here in the previous one, the scrotum is reasonably well developed, and they really don't require to be operated. There are very rare cases where you will need to operate these patients. One is, of course, if it is really a non-descended or an undescended testis. Suppose retractile testes can also undergo torsion. So if there is a history suggestive of an aborted torsion or a subclinical torsion, then these are the patients whom you need to fix, because if they have undergone torsion, you don't want a second torsion. If there's a unilateral small testes, possibly this child has had a torsion, and that may again be an indication for operation earlier. Coming to an emergency in children, and that is a red scrotum. You can see in this picture that it's a unilateral scrotum which is swollen, which is red, and the possibilities here are testicular torsion or epididymal orchitis. Obviously, epididymal orchitis by itself does not require surgery, but testicular torsion requires early surgery. Now, the important thing is to identify them. And unfortunately, sonography, sorry. Unfortunately, sonography is not a good enough measure to really rule out torsion. And of course, we all know that sonography is operator dependent, but in general, there can be fallacies in sonography identification. We are well aware that if a torsion testis surgery is delayed abnormally, then not only this testis is going to get harmed, but there are also suggestions that the contralateral testis may get harmed because of that. So rather than wasting time on investigations or doing some sort of time pass in the form of giving antibiotics and watching this patient for 24, 48 hours, the safest thing is to go ahead and explore. So these are the patients who the best is to explore early, rule out a torsion, even if it is just an epididymal orchitis. You have done very little harm, but if you would have missed a torsion, you have done significant harm. So that is what I said, that you have to weigh the plus and minuses in each case, and depending on that, you take a decision of what you want to do. Chronic constipation is another problem which is very often referred to pediatric surgeons with the assumption that this is a Hirschsprung's disease. Unfortunately, it is one of the most common misreported radiological diagnoses that me and my colleagues would all feel. And for some reason, the radiologists seem to diagnose Hirschsprung's disease far often than what they are actually there. A simple clinical assessment which you can do is that if the constipation is since birth, or has the constipation started after 5 to 6 months of age. So if it has started after 5 to 6 months of age, less chances of this being a Hirschsprung's. If the constipation is there since birth, far more chances of this. Whether there is soiling or no soiling, again, none of these are absolute things, but a child who is regularly soiling his underpants with constipation is less likely to be a Hirschsprung's. These are simple clinical things which you as practicing doctors would be able to assess and decide when to refer and or not to refer, that sort of thing. Of course, In many of these patients, we need to identify a simple other condition, which is called an anal stenosis. Here you can see that this anus is stenosed. It is a little bit anteriorly placed as compared to the normal anus. You can see that this is the place where the normal anus should have been, and this anus was more anteriorly placed. These are conditions which are called either anal stenosis, ectopic anus, anocutaneous fistula, different terminologies. Well, essentially, they will all cause constipation and they will all require surgery. Coming to another common condition where there's a lot of panic, parents panic, sometimes the referring doctor also panics, has panic on this, and that is coin foreign bodies. I'm going to restrict this talk to coin foreign bodies because they are relatively very safe foreign bodies. Some of the other foreign bodies we are not going to discuss. That will take a lot of time. So I'm not going to discuss, restricting it to only coin foreign bodies. So coin foreign bodies are relatively safer foreign bodies. Now, please keep in mind, the narrowest portion of the entire GI tract is the esophagus itself. In fact, the beginning of the esophagus is the narrowest portion, but the entire esophagus is the narrowest portion. So if the foreign body is able to pass through the esophagus, then most likely it will pass through the entire GI tract. And that is what our observation, which most of us in pediatric surgery would be able to tell you. So if it has gone to the stomach, no aggressive, I'm talking of coins, no aggressive intervention needs to be done if it has gone into the stomach. It's only if it is in the esophagus that it needs to be extracted because it may get stuck. Another thing is the presence of coin for a long time, even in the body, even if it takes a long time for it to pass out, is not going to be harmful to the child. In recent times, there has been a lot of talk of treating acute appendicitis conservatively. Well, so coming to those acute appendicitis which are seen below 5 years of age, please note that these are the patients, the possibility of complications because of acute appendicitis is reasonably high in these patients. Peritonitis, intraperitoneal abscesses are well known. Not only that, portal pyemia, liver abscesses are also known in these patients. So an acute appendicitis below 5 years can give rise to a variety of complications. And here you can see the perforations, here you can see all these adhesions which are there because of peritonitis. The adhesions which are there, the momentum getting adherent. So all sorts of complications are possible in acute appendicitis. And these complications can have a lot of morbidity, long-term morbidity also in children. Even above 5 years, the safest option is surgery. Because all these complications which we have seen below 5 years can also take place in above 5 years, although in below 5 years, they are far more common and they can be far worse as compared to its morbidity. In children, there is no contraindication for doing surgery after 48 hours. So even if the problem is 48 hours old or if there's query lump formation, there is no contraindication to doing surgery because the possibility of complications being higher in children, you don't conserve an acute appendicitis, ideally speaking. And only thing, surgery can become a little bit more challenging after 48 hours. So better to operate these patients earlier. Coming to intussusception, again, another common condition. Here again, there is a little confusion amongst members. So the primary intussusception invariably does not have a pathological reason. And nowadays, it works very well to treat these patients either by saline enema under sonographic control or anemia earlier, which we were doing under radiological control. And if you pick up these patients early, then the results are excellent. You don't require to operate them. But what is important is that a pediatric surgeon needs to evaluate these patients. Because in case the saline enema fails or the barium enema fails, then these patients need to be taken up urgently and urgently, I am saying, for surgery. And here, if you delay, then if there has been a perforation in the saline enema or any of these things, and if the delay is there, then that can be very bad. So if the saline enema process gets complicated, so please see to it that you have involved a pediatric surgeon before attempting any of these things, so that he is mentally ready that in case there is a problem, then he or she is in a position to take up the patient for surgery as early as possible, just in case there is a problem. But please note that the enemas work very well, especially if they are seen in the first 24 hours. Even a little later also they work, but first 24 hours, they work very well. These are primary intussusceptions we are talking of. But we are seeing children, older children, 5 years old, 7 years old with intussusception. I'm not talking of transient intussusceptions, which are there for a short time, but recurrent intussusceptions. And these patients are likely to have polyp, lymphomas. And you can see this particular bowel, which we just took it out. And you can see this particular lesion over here. This from the outside, you can see that this lesion, this is the area which was depressed from the serosa. And when we opened this lesion, you can see this. This is the lymphoma, which was inside the bowel. And this was causing recurrent intussusceptions. So these are the patients whom you need to pick up early. In case there is a history of recurrent intussusception in an older child, as I said, 4 or 5 year old, these are the patients you don't take to enema reduction and do time pass, but operate them early, get the bowel out, get the tissue for diagnosis, and if there is a lymphoma or something of that sort, then treat these patients immediately and save their overall long-term prognosis. Yeah, I'll just take 1 or 2 more. I have 2 to 3 minutes more, and then we will wind up. Gastroesophageal reflux, again, reasonably common problem in small babies. In most babies, this is a self-relieving condition and does not require surgery. In fact, internationally also, indications for surgery are rapidly declining. However, if there is a near-miss SIDS, if there is a repeated LRTI, failure to thrive, these would be relative indications for surgery for gastroesophageal reflux. But otherwise, these patients don't require surgery. Antenatally diagnosed hydronephrosis is becoming more and more common nowadays because of antenatal scans and the radiologist picking up even the smallest amount of dilatation on the antenatal scans and causing a lot of stress to the parents. They are very much worried. As I'm not going to discuss the whole gamut of antenatal hydronephrosis, because as I said, this is, but which are the cases where one needs to be alert? So if you are seeing a bilateral hydronephrosis, even a small quantity or a mild hydronephrosis in a male child, there is a need to rule out posterior urethral valves, because these are potentially harmful conditions and they can do a lot of harm in the long term. So if you sort of ignore these patients for a long time, they can do a significant harm to the kidneys. So posterior urethral valves has to be ruled out in a bilateral case. In case there is a ureteric dilatation, then you need to rule out a vesico-ureteric reflux and put these patients on medical line of treatment for vesico-ureteric reflux at least. And maybe surgery will have to be considered in select cases as and when there is a need. But at least these 2 things has to be. So if you see a patient of hydronephrosis, especially the bilateral ones, even if mild, if it's a male child, rule out the posterior valves at the urethra level, just distal to the bladder. And if you see dilatation of the ureter, rule out a vesico-ureteric on the sonography. So these are the 2 things that need to be ruled out. Surgery, of course, is selective. And the last thing I wanted to discuss was somebody's talking on neurogenic bladder. I don't know. So neurogenic bladder again is something which we are seeing in a because in some children, And unfortunately, there is less awareness that many of these children can be given a reasonably good life. Even if we can't really operate directly on them, but they can be given a good life, because it's a very disturbing condition for the child as well as the family. The foul smell forces the child to become a recluse. In fact, if you see these children, most of these children whom we see are 5, 6, 7, 8 years old. They don't go to the school because everybody is teasing them because they're smelling, they're stinking. And they obviously are becoming very conscious about it. The parents also cause a lot of embarrassment to them. And diapers and cost of all this is really financially also depleting. So these are the patients. Of course, very often, many of these neurogenic bladders, if they have got hydroureteronephrosis, their kidneys are going to get spoiled, and they are going to go into CRF. So very soon. So one has to be very alert on these patients. But a timely surgery for the neurogenic bladder can make these children socially far, far more acceptable. They can be living a normal life. They can be contributing to society over a period of time. So these are the patients one has to identify and treat them. Usually by about 5 years of age, we put these patients on surgical treatment for the neurogenic bladder. But they require a detailed evaluation. We are not going to discuss the detailed evaluation. But please be aware that in case you see these patients, then they can be given a good life. And that is important because these are otherwise normal children and we can give them a normal life. That's important. Thank you very much for a patient hearing. And I'm now going to request my colleague, Dr. Nargish, to give her talk. Question answer about question answer कैसे करेंगे?
Let me finish then we do
Yeah.
the same.
Sarita is also doing online.
Good afternoon, everybody. My topic today is the abdominal cysts in children. These are the cystic lesions that you see in a child in our pediatric practice. Now, what can you define the cyst as a sac which is filled with liquid or semi-solid content? It usually has an epithelial lining. So many times there is a cyst without an epithelial lining, and then you call it a pseudocyst. I have tried to make it a very concise presentation because it's a very wide subject, and depending upon from where the cyst is arising, I have classified them. Cyst arising from the solid organs of the abdomen. Then second is the mesentery, from where the cyst can arise. And the last is the bowel. Now, solid organs will be, first one is the hepatobiliary system and the liver. You see liver cysts, simple liver cyst. Liver abscesses are quite common. You can see the hydatid cyst also. Choledochal cyst, which every pediatric surgeon is familiar with. The renal, that is arising from the kidney, main is hydronephrosis. Nowadays, with sonography, we don't usually see the big cystic hydronephrosis, but if it is a very huge hydronephrosis, you feel the cyst, renal abscesses, multicystic kidney, then there is a cystic nephroma, cystic Wilms tumor, and the last one is the urachal cyst. Pancreas, you see the pseudocyst of pancreas. Everybody comes across once in a while. Spleen, the splenic cysts are not so common, but you do see the splenic cysts, splenic abscesses, and the vascular malformation of the spleen. Arising from the adrenal also, cystic neuroblastoma or adrenal hemorrhage. And the ovaries in a female child, which would give rise to ovarian cyst or paraovarian. Mesentery. You see the mesenteric cyst, it can be lymphatic or chyle cyst, then the omental cyst. This is a CSF collection which you see in patients with hydrocephalus post-revision. And then these are the pseudocysts. These are not lined by an epithelium. Abscesses intra-abdominal. This is giant cystic meconium peritonitis, where it is a pseudocyst. And there is a perforation antenatally, weeks before the delivery. The meconium comes out, forms a collection, and the cyst is lined by the normal intestinal loop. There is no epithelial lining. Then there is a cystic teratoma, cystic lymphangiomas or cystic hyperomas, whatever you call it. And the last is the bowel. Bowel, mainly it is the intestinal duplications. Cystic lesions of the abdomen are not so common, but they are not so rare either. And you come across these cystic lesions quite often. There is no age bar. At any age you see it. In any sex, male, female, both the children are affected. Antenatal diagnosis is also nowadays many times they tell you the cyst in the abdomen. When the child is born, then also we can detect neonatal age cases. And the older. Now let us see generally what will be the symptoms and the signs of abdominal cystic lesions. First of all, it depends upon from where the cyst is arising. So depends upon the organ of origin, depends upon the size of the cyst, and then the location where it is situated. It's a huge cyst, you will feel the lump in there. This lump will, if you see it is a mesenteric cyst, then the lump is usually you can move it transversely, diagonal to the root of the mesentery. If it is an omental cyst, then also it's a mobile lump and you can move it up and down as well. Hydronecrosis, anything that is arising, any cystic lump arising from the kidney will be ballotable. Usually it is restricted on one flank and it usually doesn't cross the midline. Occasionally it does that also. An ovarian cyst, which is really mobile in the abdomen. The child may present with a pain in the abdomen. It's a dull ache for so many years, like months, years also. And people will miss it why it is happening. Or they can come with a colicky pain and an acute abdomen. So both the ways it is true. If there is a chronic cyst in the abdomen, then the pain will be very dull till the cyst becomes big. And if the cyst rotates, come with the acute. Distension of abdomen you see whenever there is a intestinal obstruction. It occurs because of the cyst, and a large cyst also will cause distension of the intestinal obstructions, all the symptoms like vomiting, fever, if there is a duplication cyst which is rotated and causing intestinal obstruction. Blood in stool is not so commonly seen, but you do see them, and that is clinches the diagnosis of duplication cyst. Wherever there is a gastric ectopic mucosa and it's a communicating cyst, so then you get blood in stool. Blood in urine with vesicle or infra-umbilical pain will give suspicion of a urethral cyst. And at least so many times it's only coincidental finding. You are investigating the child for something else and suddenly there is a cyst in the abdomen, arising either from the liver, spleen, kidney, or ovary. You have to elicit these signs that the lump, you can differentiate different lumps. Tenderness depends upon the torsion, intestinal obstructions, so you are all familiar with the signs. Now, diagnosis. How will you diagnose? Sonography, it's a gold standard. Nowadays, as my previous colleague told, antenatal diagnosis. Then neonate, once the child is born, you can get the sonography done and come to the conclusion if the cyst is there and what kind of cyst it is. And if the older child is presented to you, then also sonography is the first modality. CT scan, you do require CT sometimes to differentiate between the different type of cyst, especially when it's a very large cyst of the whole abdomen and you are not sure from where it is arising. MRI very rarely. And it is organ specific test, MRCP for polylocal cysts, Meckel scan to rule out ectopic gastric mucosa in a duplication cyst, the tumor markers if there is a cystic teratoma if you have suspect. Now, how do you treat this cyst? Now, all the cystic lesions in the abdomen in a child are not for the excision. So many times you just observe them, coincidental findings, especially the asymptomatic ones. Don't do anything. If there is a liver cyst, it is not causing any problem, and you find an accidental finding. Even if it is a little big but not causing obstruction to the hepatobiliary system, then please observe them. So many times you have seen them becoming small. The same thing goes to mesenteric cyst. So many times in a newborn, a small cyst, don't jump into it and start if it requires surgery. You can observe the child, even the ovarian cyst in a newborn. Just observe them. So many times they are bound to disappear or reduce in size. Otherwise, in an older child, if you see a cyst which is symptomatic, that means it is causing either pain, causing obstruction, intestinal, causing hepatobiliary system obstruction, then excision is a must. Excise it with a minimal invasive surgery, endoscopy. Either you open the abdomen, do a laparotomy, or laparoscopic assisted excision of the cyst. So, total excision is a must for symptomatic cyst. So many times that is not possible as far as the duplication cysts are concerned, you can't. So then resection anastomosis, but remove the whole cyst. And partial excision also, so many times, but remove the mucosa of the cyst. It's like a marsupial excision. I'll show you a few slides, so you will have some idea how we do it. Now this is a child referred to me immediately after birth with this big abdomen. Sonography antenatal was suggestive of some cyst in the abdominal cavity. Then we did the sonography post-birth. There was a little bit of calcification also present, so we decided it is a giant meconium cyst. This is actually a pseudocyst, as I told you before. It is because of the leak of the meconium in the peritoneal cavity. The intestine gets adhered and forms pseudocysts. This requires surgery immediately. You can't wait on this. Here I have done laparotomy. Couldn't see any perforation anywhere. Usually that is the case because everything is sealed up. I did a ileostomy because I thought maybe there is some distal problem or springs or something going on here. And then the child survived nicely after 5 or 6 months of age, I did the rectal biopsy, which was negative, and I closed them. Now look at it. Okay. This is a little older child. See the size of the cyst. It was so huge. I didn't know how the child was able to bear it. And because these lesions are continuously for many months or many years, the child gets used to that weight in the abdomen. This is a chylous cyst. You can see the yellow colored chyle. I had to do resection anastomosis. Only a small part of the intestine was involved like that. Otherwise, it was arising from both the leaves of the mesentery. Can make it out. This is a duplication. It's the same thing, but it is not in the two leaves of the mesentery. And there is usually a communication with the intestine, or sometimes there is no communication. Now this is the way I have done it. I had to subject the child and do a resection anastomosis. Now this is a very rare kind of duplication. It is actually a stomach duplication, but at the antrum of the stomach. And these children are usually they present at the age of 1.5 to 2 months. All the symptoms are typical that of infantile pyloric stenosis. Because the obstruction is at the antrum of the pylorus, they have non-bilious vomiting, they have visible gastric peristalsis, they are not tolerating pills. Here also I got a call that the child is having infantile hypertrophic pyloric stenosis. When I saw the baby, I could see the gastric peristalsis, but there was a lump which is persistent in the right hypochondria. The sonography said it is a polytopic cyst. So we had to resort to CT to know what it is. And the CT people told us it is a duplication cyst arising from the stomach. Here, even if I want to remove the whole cyst, it is not possible. You have to sacrifice the organ, which I didn't want to do it. So the cyst was excised as much as possible. It is sharing the wall, seromuscular wall with the stomach. So I have done the marsupialization, remove the mucosa, whatever I do, remove. And then left. This is another case. Distension of abdomen, big abdomen, lump in the abdomen. You see the sonography of CT. This, you can see the cyst just behind the anterior abdominal wall. So these are the omental cysts. And when I opened up, I didn't know what I was dealing with. And then I realized that it was an omental cyst. The omental must have got rotated on its own, causing necrosis of the omentum inside the cyst. This is a simple liver cyst. I had to operate on this patient because it was symptomatic. It was causing pain, colicky pain because of compression on the hepatobiliary system. The child was otherwise not jaundice, but because of pain, I had to operate. A typical hydrated cyst of the liver, we have to excise it, we have to remove this. This is ovarian cyst. Very commonly we see it in a girl child. Now here also, as I told you, not all ovarian cysts requires to be excised. It's a small cyst, smaller than 7 centimeters. The child is a good observation, and you can wait on it. So many times, as there is hormonal imbalance settles, so many times they regress in size, and you may get away with it. Only danger is the rotation or the torsion, and you have to be very careful. You have to counsel the parents also. Nowadays, with scopy and ovarian sparing surgery, it is quite reasonably good prognosis, but unless there is a need, please don't operate. This is a typical of polytopic cyst, the nose cyst. Thank you so much. Any questions or anything to both of us? Questions from anybody?
Questions are again.
And then?
Yeah.
Good luck.
Are there any questions to either of us? How question is? Are they going to ask questions on the chat?
Sure.
Any questions? They're all muted. I think. कैसे question? कैसे वो लोग
Can you
muted?
see them or they can see you?
If anybody has question, you may please raise your hand.
You can see.
Or you can put them in the chat box. Okay. Then we'll go to the next presentation.
Yes. Yeah, my Dr. Kali.
Sarita Bhagwat.
Good afternoon, ladies and gentlemen. I'm Dr. Sarita, Pediatric surgeon. We are going to talk about neonatal intestinal obstructions. If we consider all the surgical NICU admissions, about 25 to 30% of them lead to intestinal obstruction. These neonatal intestinal obstructions are either organic or mechanical, or they can be functional or adynamic, like IBS, necrotizing enterocolitis, and things like that. So when the family is celebrating the arrival of the newborn, suddenly there is distension, the baby becomes cranky, refuses to feed, there is vomiting, and usually the baby is taken to a neonatologist or a pediatrician, and things take a different turn there. So if we go through the causes of neonatal intestinal obstruction, we can widely divide it into organic and functional. As I said, in the organic, there can be problems in the wall itself, or it can be outside the wall, or in the lumen of the wall. In the lumen of the bowel. So in the wall, we have atresia. So part of the intestine is not formed. These are actually intestine is formed by canalization. There are small vacuoles which appear in a solid cylinder, and all these vacuoles then coalesce to form the lumen of the bowel. So, if bowel is already formed and there is a secondary vascular accident to one of the vessels which are supplying that part of the intestine, that vessel undergoes a sudden blockage and the intestine will then become narrow, ischemic, and form a atretic segment. So usually these are late events in the during the gestation, and atresias are of several types. Either just a membrane without a hole, or there can be a gap in the between the two ends of the intestine with intact mesentery, or there can be a rent in the mesentery, or you can have a Christmas tree appearance. Then the other causes in the wall of the intestine is volvulus. Like the root of the mesentery is short, so the entire gut along that root of the mesentery undergoes volvulus. If we consider outside the wall of the intestine, then we have bands like malrotation, which are the latch bands and resulting into a volvulus, or adhesions of different kinds. Now you will wonder why there should be adhesions in a newborn abdomen, because it's a virgin abdomen. But sometimes there is a leak of the meconium due to various causes, and depending on the leak, amount of leak, duration when it has happened, and what is the body's response of that baby to this leak, there can be adhesions. There can also be adhesions because of remaining vitaline vessels. As you know, there is a vitalointestinal duct which persists in 2% of the babies, and the vitaline vessel can have the intestinal loop can go between the vitaline vessel and the mesentery and have obstruction. As Dr. Nargish told you, there can be various kinds of cysts like duplication, chylolymphatic cysts, giant cystic meconium peritonitis. These also can present as intestinal obstructions. Especially the obstruction caused by meconium peritonitis, they present very early. Soon after the birth, within 2-3 hours, the baby gets severe distension, there with or without vomiting, and the team is alerted. Now, if you consider inside the lumen of the bowel, you have a meconium plug, a single plug, which may be just a plug and then the baby becomes better, or it can be it can give you a signal that there can be an underlying Hirschsprung's disease. You have another case called meconium ileus. So in meconium ileus, there is a problem with the exocrine pancreatic exocrine pancreatic component. So all the enzymes, digestive enzymes which are secreted by the pancreas, they are deficient, and hence the meconium is very thick and viscid. And intestines, peristalsis, normal peristalsis are just not able to move there into the colon. So it gets inspissated in the terminal ileum, giving rise to low intestinal obstruction. Nowadays, we also find that some of the formulas or very thick viscid milk can also cause inspissation. Other causes of organic intestinal obstructions in a newborn are obstructed hernias and a missed anorectal malformation. Now we go to functional problems of neonatal intestinal obstruction, and functional problems will be prematurity and low birth weight, which can give rise to ileus or little delayed peristalsis, ileus due to sepsis, necrotizing enterocolitis, and Hirschsprung's disease. So, if we go through the physiology of the intestinal obstruction in a newborn, because of obstruction, there is proximal dilatation. This gives rise to abdominal distension. Now, in addition to abdominal distension, there is third space loss within the proximal segment of the bowel, proximal to the obstruction. So, a lot of fluid is inside the lumen, the dilated bowel lumen, and that can give rise to dehydration, hypotension. It can also, depending upon the amount of distension, there can be splinting of the diaphragm. Now, as you know, the proximal contents are let out by the baby by vomiting. This can be gastric or bilious depending on where the level of the obstruction is, and this incurs a lot of losses of fluids and electrolytes. Also, the baby is at risk of aspiration and pneumonitis when the baby is vomiting. Now, in severe intestinal dilatation, like in meconium peritonitis or any perforation, there is exudative loss by the peritoneum itself. Or if there is a necrotic gangrenous bowel, like in NEC, there will be peritonitis, and this can also lead to shock, poor tissue perfusion, and metabolic acidosis. So, all this you will come to know after examining the baby. So, what are the key things that we look into? We look at the pulse rate. Is there any tachycardia? Is there any hypotension? Is there any abnormal capillary refill time, which is usually 2 to 4 seconds? And if it is delayed, then you know that perfusion is not good. Baby also looks mottled. Then you know that baby requires to be taken to a neonatologist and a surgeon, and we assess the baby and start the IV drip in addition to decompressing the bowel by nasogastric or orogastric tube, and try to see what the problem is. So, as I told you, presentation will be distension, bilious vomiting, failure to pass meconium, or if it is a little later, after 1 week or so, maybe is been passing meconium, then had obstipation and has been brought to you for intestinal obstruction. So you have to also find out when did the baby last pass stool and when did the baby last pass urine. This will tell you how is the state of hydration of the baby. So you can see this baby has got distension more in the upper abdomen, and you can see dilated bowel loops. The baby is just going to receive anesthesia. We have put a urine bag there so that we can measure the urine output. The investigations that we do or we ask for before taking the baby, in addition to the blood investigation, CBC, CRP, blood grouping, cross-matching, whether the coagulation profile is normal, how are the electrolytes, what is the lactate, telling you how much is the hydration or dehydration, extent of dehydration. So the commonest imaging modality is plain X-ray abdomen, most important, because air is the best contrast for a baby and it gives minimum of the radiation. So plain X-ray abdomen, usually the surgeons like a erect or a standing film, but so many times the babies are very sick and you may have to diagnose the condition on supine films, or we can ask right or left decubitors to know whether there are air fluid levels. The next investigation will be sonography. It will tell us whether bowel peristalsis are there or they are adynamic loops. How much is the fluid inside the peritoneal cavity? Is there any gas in the wall of the intestine like in NEC? Is there any portal vein gas? Is there a free gas? Of course, under the diaphragm will be known by taking the X-ray of the abdomen. Very rarely we ask for a contrast enema, but very specific indication. If there is delayed passage of meconium, suggestive of Hirschsprung, or if you have multiple dilated loops, but there are no air fluid levels, suggestive of meconium ileus, then you will do a contrast enema to diagnose. Very rarely we ask for a magnetic MRI or some other investigation or a CT scan, especially when there is a tumor compressing the bowel and causing obstruction. We will discuss about this contrast enema a little later in one of the next slides. So management starts with getting the baby into NICU, baby is made NBM. So whenever you are transferring a baby for neonatal intestinal obstruction, please do remember to send mother's blood, because even if we are doing baby's blood group, we have to cross match with mother's blood, as mother's antibodies are there till 6 months. So till 6 months of age, we require mother's sample to cross match. Baby is made NBN, orogastric or nasogastric tube is put to decompress the proximal intestine. IV fluids are started and resuscitation is started to take care of the third space loss within the intestinal lumen, the exudates which are there in the peritoneal cavity, and to get the electrolytes normal. X-ray is usually asked and we send the blood for grouping, cross-matching, we check the INR or any coagulation profile and then take the baby for surgery. Now, we'll go through some of the causes of intestinal obstruction, and I'll go through I'll take you through some of the conditions very quickly. So, neonatal atresia is one such condition where the baby will manifest very soon after the birth. Most of the times it is antenatally diagnosed because there is a double bubble, and as you know, the babies are also swallowing the amniotic fluid. So they, when there is a proximal obstruction, they know they cannot swallow all that because there is a ceiling, and that is why there will be polyhydramnios. Whenever there is a double bubble appearance, the sonologist is smart enough to look for cardiac anomalies and to rule out trisomy 21. So they will look for soft markers of trisomy 21 like nuchal fold thickness and other things. We can also, if we are sure that trisomy 21 is likely, we will do a karyotype antenatally to know whether it is trisomy 21 so that we can counsel the relative. Now, presentation after birth will be, this condition does not require any cesarean section, but it depends on the mother's parameters and the baby's parameters. Now, after the birth, the baby will present with upper abdominal distension and vomiting. If it is pre-ampullary, it will be gastric. If it is post-ampullary, it will be bilious vomiting. And associated with duodenal atresia, there will be soft markers of trisomy 21 Down syndrome, or there can be associated cardiac anomalies, vacuoesophageal fistula, and rectal malformations. So, baby is assessed from this point of view. Whether the NG is going across, whether the anus is there, maybe as past meconium, what is there on 2D. Then investigations, as I told you, blood investigations, X-ray and 2D echo. Now, this is one of the very old X-rays, as you can read the date, and somebody has done a dye study to see that it is a duodenal atresia. There is a single bubble actually on plain X-ray, and if the person would have aspirated little more contents and pushed little air, he would have got double bubble. So the contrast study shows that it is entering the D1 part of the duodenum, just about to reach the D2, and there is atresia beyond that. So management is duodenoscopy, which is done in the newborn period itself and gives very good and gratifying results. Now we'll see what are the other differential diagnoses. So this was a baby who came on in the 3rd week of life and with bilious vomiting. Baby was all upright till first 3 weeks of life. Had sudden onset bilious vomiting. But as you can see, X-ray shows that there is a double bubble in the upper abdomen, but there is some distal gas in the colon. So there has to be some other diagnosis. So the person has done a contrast study. And what does the contrast study show? Contrast study shows a large stomach, a large duodenum till D2, and beyond D2, there is no contrast going, but there is air has already gone. So there is an obstruction at D2, 3, but what is the cause we don't know. So what are the differentials in this condition? There can be volvulus due to malrotation. So there has been a malrotation right from birth or still before birth, but it will not manifest till the baby gets volvulus of the small intestine of the midgut. So on sonography, during volvulus, SMA, superior mesenteric artery and vein axis is changed. Usually artery is medial, vein is lateral. But during volvulus, this relation changes and the sonologist is able to pick up this sign suggesting that there is a volvulus. But mind you, if the baby is sent during an episode when there is no volvulus, the sonologist will not be able to pick up any changes in the SMA assembly. Okay. So other diagnosis will be duodenal diaphragm with a central fenestration, which is another type of atresia where the central fenestration is there. So things were going across and now it has resulted into proper obstruction. Other differential can be annular pancreas. So malrotation with volvulus is usually a very emergency situation. As you know, the baby will manifest with bilious vomiting with or without distension. Late manifestation will be bleeding per rectally because of the ischemia of the midgut. and it is an emergency situation. We do an ultrasound to diagnose the SMA-SMB axis change and to diagnose a malrotation. This is the X-ray contrast study which shows that the stomach is there, then there is a obstruction at D2-3 level, and little bit of the contrast is gone. But if you can see here that the DJ junction, duodenojejunal junction, which is normally placed on the left of the midline, it is on the right of the midline or near the midline, suggesting that the gut has not rotated completely. And this results into a narrow mesentery of the midgut and around which the baby has undergone volvulus. And surgery is very gratifying. It gives rise to very good results. Its malrotation correction can be done either laparoscopically or open. So this is one of the unfortunate babies who came very late during malrotation, and most of the midgut has undergone gangrene. Now this gangrenous gut cannot be left inside, has to be resected, and it may result into a short gut syndrome. Another condition, abdominal distension, bilious vomiting may or may not pass meconium, and always transfer such babies with a sample of mother's blood. You can see in top picture that proximal gut is all dilated. Okay, there is no rent in the mesentery, but the distal gut is all collapsed, and this is a type of atresia, type 1 intestinal atresia. Resection anastomosis gives very gratifying results, and baby will live as long as you and me. This is another type of intestinal atresia. As I told you, that first one was type 1, where there was no rent in the mesentery also. Type 2 will be two ends of the bowel, dilated and collapsed, are joined by a string of mesentery. Whereas type 3 will be a gap in the mesentery, and this is type 4. That is called as Christmas tree appearance. This is a severe problem where the jejunum is fed, and around this vessel axis, the intestine has undergone something like Christmas tree malformation. Now, if when we are doing a resection anastomosis, we cannot resect too much of gut. We don't want short gut syndrome. But at the same time, because of this Christmas tree, there are changes, ischemic changes in the bowel, and your anastomosis is at stake. This is another baby who's come with meconium peritonitis. So, in meconium peritonitis, as I said, the babies manifest very soon after the birth. There is lot of distension, disproportionate distension of the abdomen. It can be antenatally diagnosed. Meconium will leak out, and that will cause some inflammatory response, and calcium gets deposited. So the sonologist will pick up calcification in the abdominal cavity of the fetus to diagnose a condition that there has been leak of the meconium, and baby is going to have problems. So, depending upon how much is the leak, at what age the leak has happened, how much is the contamination, and how much is the body's response to this inflammation. So you can have minimum changes, just calcification, but baby is not manifesting, so you sit tight on this baby. Or there can be a severe spillage, so that the entire greater sac becomes a cyst full of meconium, and the entire intestine is on the back wall of the cyst. This is called as giant cystic meconium peritonitis, and the plain X-ray abdomen again gives you a clue, because there is a large air fluid level which is more than half of the abdomen. That suggests that there is a giant cystic meconium peritonitis. You can see this on the right hand side. You can see a picture. We have opened the abdomen actually, but the whole thing is form a cocoon. So this cocoon, you have to enter the cocoon, you will find only meconium. You have to enter the back wall of the cocoon, then you will find the intestine. So the entire greater sac has become a cocoon, and behind that will be intestine. So depending on the primary pathology, whether it is atresia, volvulus, you have to treat that. You may or may not do anastomosis in the same sitting. That is depending on the general condition of the baby, because your resection anastomosis will take at least 1.5 hours, whether the anesthetist is taking that much risk maybe gives that much time for the surgeon and anesthetist to take that risk. How much is the contamination? If it is a very abdominal cavity to widen down and then do a delayed stoma closure. Condition of the bowel, if the bowel vascularity good to do the anastomosis. Okay, now we come to another condition called meconium ileus. As I told you, this is a condition because of exocrine pancreatic deficiency. Some of these babies are having cystic fibrosis, so all the exocrine glands of the entire body are affected, as you know. So, because of the exocrine pancreatic deficiency, the meconium which is formed, which should have been very liquid, it becomes very viscid. And so much so that if you put a forceps, it will stand in that meconium. It will not even fall down by gravity. That thick, that viscid is the meconium. And the baby is not the normal peristalsis, hyperperistalsis. The baby is not able to push this meconium beyond the terminal ileum. So the entire colon becomes unused. So entire colon is microcolon, and as your contrast study, when you are doing it, it enters the terminal ileum, you can see the pellets of the meconium. And then there will be thick viscid meconium. Now, presentation is distension, vomiting, visible loops. Baby has not passed meconium, so you do a rectal examination, it is empty. You can give washes, but hardly anything comes out. You take a X-ray abdomen, it will show dilated bowel loops, but in spite of taking the X-ray in erect position, there are no air fluid levels. Now, why there are no air fluid levels? Because the viscid meconium, it just doesn't settle. It just doesn't settle down. And so it is everywhere. So the air is entrapped within this meconium, but it does not allow it to form an air fluid level. This is very classical of meconium ileus. And you will do a contrast study to diagnose it, and there are various methods. We'll go through it, how we can treat it. So initially diagnostic will be enema, then IV fluids, maintaining the temperature, pulse, respiration, abdominal girth, and urine output. Now, if there are uncomplicated cases of meconium ileus, you can just give diluted gastrograph in enemas, and post enema we monitor the babies, and within 2 to 6 hours the baby will start passing the meconium. Because gastrographin has a mucolytic action, it has a hygroscopic action. So hygroscopic, so you are supposed to maintain good volume, intravascular volume of the baby. So fluids will be drawn within the lumen of the intestine. So the meconium slides along it, and the mucolytic part will lies that thick viscid meconium. So this is how they are treated. So post enema, again you have to monitor, because there are lots of fluid changes across the wall of the intestine. They can result into NEC, they can have perforation. So this is to be done very guarded, and you have to monitor these babies. If it is a complicated case of meconium ileus, then you have no option. You have to go in and operate. Depending upon the bowel condition, you may do open the intestine, take out all the viscid meconium, and close it primarily, the endotomy. And you are giving a lot of exocrine pancreatic supplements like creon and orally. And you may also give gastrographin or N-acetylcysteine orally in diluted forms, so that the next meconium which is coming across will be thin. You can do in a complicated meconium ileus with a bowel segment which is gangrenous because of volvulus, because of the weight of the intestine which is having loads of meconium. You can do a stoma by resecting that non-viable bowel. So post-operatively, you have to take special care of the lungs of the baby, because some of them will have cystic fibrosis and they will result in the pulmonary complications. You will also do a genetic study to rule out cystic fibrosis or prove it. These babies are kept on oral pancreatic enzyme supplements. This may be transient or it may be permanent. Now, Dr. Nargish has already spoken about this. 2-week-old baby with distension of abdomen, no vomiting, passing stools well, but lump was felt, and this is a very classical case of duplication cyst. So you can see it is in the mesenteric side of the bowel that the duplication is there, and we have to resect a small bit of intestine and do a resection analysis. Other cases of intestinal obstruction, newborns, obstructed neonatal hernia, inguinal hernia. Obstruction is dangerous because it gets noticed quite late when the intestinal obstruction happens. You will try to reduce it and it requires a repair as early as possible. Now, necrotizing enterocolitis. This is a very peculiar condition restricted to this newborn age. As we know that many with the better survival of prematures and low birth weight babies, we also find certain conditions which are limited to that period, that group of patients. So in these babies, there is impaired gut barrier. So there is translocation of the transmigration of the bacteria across the wall of the intestine is very common. This is again also predisposing agents are there, like early feeding. We want to feed them early so that we get rid of the anemia. And sometimes we have to give hyperosmolar formulas, medications. There are certain infectious agents which are very common. With the breastfed babies, Bifidobacter is common. With the formula fed baby, E. coli and bacteroids are more common causing AIDS. Now, preoperatively optimization, necrotizing enterocolitis has various phases, whereby there will be just an ischemia. Ischemia may be so severe that there is gangrene. There can be infarction with perforation of the intestine, and most commonly it is seen in watershed areas. Watershed areas where the one artery supply and the other artery supply are just meeting. So terminal ileum, ileocolic junction is one condition, one place where it can be common. It is common in the colon, transverse colon, where the middle colic and left colic are meeting, the boundaries of blood vascular supply. And depending on the condition of the baby and the bowel, you will tailor your surgery and treatment. So pre-op optimization will be treatment of shock, broad spectrum antibiotics, correction of coagulopathy. So many of them have deranged coagulation profile. They may require vitamin K, FFP before we take the baby up. Age appropriate mean arterial pressure has to be maintained, and urine output should be good before you operate. Now, investigations will be in addition to blood investigations, radiology will be plain X-ray abdomen to know whether there is pneumatosis intestinalis. That means the bowel has become ischemic and the air from the lumen has entered the wall of the intestine. That is pneumatosis intestinalis. Next phase will be portal vein gas, because this air in the wall of the bowel is picked up by the portal vein radicals and it enters the portal vein. And next will be full thickness necrosis and free gas under diaphragm. There can also be exudative fluid losses inside the abdomen, which will be picked up on sonography. Now, every baby of NEC need not be operated. There are certain babies which are picked up very soon because they are in NICU and on feeds, and everybody is watching out for NEC. So if there is a distension and a fixed loop on repeated X-rays, you need to examine them every few hours to know what is the progress of the NEC. If you know that one of the bowel loops is not moving on X-ray, the same X-ray pattern is there, that means that loop is not moving. That loop is not moving, so is it a viable loop or a non-viable loop? Is there a free pneumatosis intestinalis in that loop? So all these will make you prompt you to take decisions. So very sick baby, very late presentation of new NEC. They are in shock and they with bad coagulopathy. You cannot take them to theatre. So what you will do is you will bedside put the glove drain inside the peritoneal cavity to at least deflate that distension. We come to know how much is the fluid losses. We can send that for culture and know what is the condition. If there is a frank fecal matter, you know that bowel is perforated, this baby has to be taken up for surgery. But this will be just to buy time till the baby is stabilized. Okay, now at laparotomy you can have focal disease, just a single perforation, multifocal disease, multiple areas of bowel gangrene, or it can be pan-intestinal disease. Majority of the bowel is not looking good, ischemic. Now, length of the viable intestine and whether ileocecal valve is intact or not, that will decide how much is the final length of the intestine that you have left behind. Because you don't want the babies to have short gut syndrome, so you will try to preserve the IC valve. If it is feasible, you will try to preserve as much length of the viable intestine as possible. So surgical indications for NEC will be fixed loop with compromised vascularity and pneumoperitoneum, total vein gas. Options, we try, our motto is to save as much intestine as possible. So there, if it is a very bad condition, then we will put a drain by time. The neonatologist will resuscitate the baby, optimize the coagulation profile, then we open the baby. Depending on the condition, we may do just a stoma of the devitalized bowel. At the site of the devitalized bowel, we resect that and do a stoma. And going, sometimes if it is a pan disease, you will just give a wash. You don't know how much to preserve and how much to excise. So you will just give a wash, put big drains and close the baby, just the skin, not even the abdominal wall, and go in after 48 hours in the hope that some of the bowel has recovered. So you will resect less and you will have optimum length of the intestine. Sometimes the disease is restricted. So you are just resecting 10-20 centimeters of the bowel. You will do a resection and a stoma. Sometimes the baby doesn't give you time. You know that you want to do resection and a stoma, but there is no time because baby is hemodynamically unstable. We'll just fire a stapler, clip and drop. Drop it inside, just close the skin. After 48 hours, go in, make a stoma or make an anastomosis. Or it can be a patch, drain and wait. Or very, very rarely, a resection anastomosis in the primary setting. Very, very rare. Now we come to a very unusual cause of intestinal obstruction. Usually they present at birth itself because the first temperature to be taken of the baby should be a rectal temperature. But sometimes in a hurry, there is an anus, but there is no anus. So anus is there, but you can see that baby has developed intestinal obstruction. X-ray was taken. X-ray showed multiple air fluid levels. So low GI obstruction. Nobody examined clinically, and clinically anus like thing is there, but that pit is completely blind. So associated with lateral prone shoot through was done. You can see on the right hand side lateral prone shoot through. Their air is ascended, and it is almost very close to the skin, where the actual anal site should have been between the line drawn between the ischial tuberosity. Okay, so you can see it is almost bulging. In this first picture, you can see that bowel full of meconium is just bulging to be so that it is just telling you, just open me up and I will pass meconium. So you rule out other anomalies like ventral, vertebral, anorectal, cardiac, tracheoesophageal, renal, and limb anomalies. If it is a low anomaly like this baby, without a urethral fistula, you can do just a anocutaneous fistula, you can do a primary anoplasty without a colostomy. But so many times, boys are born with anorectal malformation with rectourethral fistula. So you have to do a colostomy, and at around 3 months of age, a definitive surgery, which may be either laparoscopic or open, and then the colostomy closure. Whereas in a female baby, vestibular fistulas are very common. Okay, so the babies are passing stools. Nobody looks where from the baby is passing stools. Nowadays with diapers it is very common. And then they suddenly realize, oh, there is no anus and baby is passing the stool from the introitus. And they come with vestibular fistula. Nowadays with good bowel preparation, we can do without having a colostomy. And with complete bowel preparation in a single stage, you can do a posterior sagittal aneurysm. Sometimes in a female baby also there is a single perineal opening and baby is passing urine as well as stool from that single opening. This maybe requires a right transverse colostomy, extensive investigations to rule out other bacterial anomalies, and then we decide how to go about it. Hirschsprung's disease. Sometimes babies have not passed or have meconium in first 24 to 48 hours, and you stimulate the baby and baby passes a large meconium plug and thereafter starts passing meconium normally. So you are relieved. This is the meconium plug syndrome, but it can be a foreteller of Hirschsprung's disease as well. Not many, all of them will have Hirschsprung, but some of them will have Hirschsprung disease. And this second picture that you can see is a baby with lot of distension. You can appreciate the distension of the abdomen. Baby is not able to pass meconium, and there are multiple air fluid levels. Here you are suspecting Hirschsprung's disease because there is no gas in the bony pelvis. So somebody has done a contrast study, and as rightly done, you can see that the A ganglionic bowel is all narrow. Then you see an ice cream cone where it is coning. That means few ganglion cells are there, not optimum. And then there is a very huge dilated part which has normal ganglion cells. So this is a case of Hirschsprung's disease. If you can adequately deflate the baby, you can do a single stage pull through without doing a colostomy. But if you cannot adequately deflate the baby, you will have to subject this baby to colostomy, either transition dose colostomy or appropriate level colostomy with multiple biopsies to prove your diagnosis, and then you will close the colostomy at a later date after the pull through is done. Okay, this is about the gist of neonatal intestinal obstruction. If there are any questions, do let me know.
Hello,
Yes.
Roju, Sarita.
Yeah, I can hear you.
Yeah, if there are no questions, then Manika will start with her talk.
Yeah, let Manika start with her talk.
Okay.
Good afternoon, everyone. I'm Dr. Manika. I'll be speaking on surgical causes of urinary tract infections. So, urinary tract infection results from ascent of bacteria from perineum up to the urethra. It is caused mostly by E. coli. One has to keep a distinction between the two types of UTI, the pyelonephritis involving the upper tract and the lower tract, that is cystitis. All febrile UTIs are considered to involve upper tract with greatest potential of renal scarring. Reflux per se does not cause urinary infection, but if reflux is present, ascent of bacteria up the ureter can cause pyelonephritis. Here, the urethritis causes cystitis, and then the pyelonephritis comes into play. Some of the important definitions has to be kept in mind. Significant bacteriuria occurs when there is more than 10 to the power 5 colony forming units of bacteria per milliliter. Complicated UTI includes fever, vomiting, features of dehydration. Recurrent UTI occurs when there is second attack of UTI. Relapsing UTI, when the UTI occurs with the same strain. Breakthrough UTI occurs when the patient is already on prophylaxis. Asymptomatic bacteriuria, growth of significant number of isolated organisms without any symptoms. So backwash or retrograde flow of urine from bladder into ureters is considered to be VUR, and it occurs up to the kidneys. So VUR is found in 50% of children with UTI. It affects a total of 1% of children. Overall, it is commonly found in commonly seen in females. 85% of VUR is detected later in life, mostly in the females. So the prevalence of VUR, if the parents are involved, then it's 50%, and it is seen in 33 to 45% if the siblings have history of VUR. It can show autosomal dominant inheritance. So the incidence of VUR in less than 1 year of age in children with UTI is about 70%. In 17.2% cases, the prevalence in children without UTIs is about 17.2%. So boys are typically diagnosed with higher grades than females. In boys, it is more common under 1 year of age. It is because of the preputial aerobic bacteria colonization is highest under 1 year. And uncircumcised infants have an increased risk of UTI as compared with the circumcised boys. Coming to the normal anatomy, phenomenon of VUR represents the balance of several factors like functional integrity of ureter, anatomical composition of VU junction, compliance of bladder. Normally, ureter has anti-reflux action, which is acted upon by active trigonal muscle contraction and passively by flap valve mechanism. This flap valve mechanism at UV junction includes oblique insertion of intramural ureter,
But
adequate.
slides are not visible.
Is it visible now?
What is it?
Only surgical cause of urinary first slide only. That's it.
Can you see now?
Yeah,
Hello?
yes. Yes, we can see slide now.
So I was telling about the normal anatomy, which is involved in phenomenon of VUR. So it is represented by balance of several factors like functional integrity of ureter, anatomical composition of VU junction, and compliance of bladder. Normally, this ureter has anti-reflux action by active trigonal muscle contraction and passively by the flap valve mechanism. Flap valve mechanism at UV junction includes the oblique insertion of intramural ureter. Ureter is composed of 3 layers of muscle, adequate length of intramural portion of the ureter, and strong detrusor support. Pathophysiology in normal ureter. When ureter inserts into trigon, distal end of ureter courses through intramural portion of bladder wall at an oblique angle. There was so the intramural tunnel length to ureteral diameter should be 5:1 in a healthy, normal, non-refluxing ureter. As the bladder fills up with urine, bladder distends and thins out, and it also causes the stretching of the ureter. The ureter becomes a bit pinched, and this functions as flap valve, and it allows a continual integrate flow of urine from ureter into the bladder, but prevents the retrograde transmission of urine from bladder back up to the kidney. There are two types of VUR, primary and secondary. Primary VUR occurs due to fundamental deficiency in function of UV junction. Here, the bladder and ureter remain normal. Reflux occurs despite adequately low pressure urine storage in bladder. The length to diameter ratio, which was described by Pequin, it is less than 5:1. It can occur due to laterally displaced orifices and deficiency of longitudinal muscles of intravesical ureter. So a shorter tunnel results into abnormal intramural junction at UV junction, and results in malfunctioning flap valve mechanism, and thereby causing VUR. The secondary VUR, here the valvular mechanism is intact, and the cause of this VUR is basically the obstruction or malfunction in urinary system. There is increased intravesical pressure secondary to neurogenic problem, bladder outlet obstruction, or bladder instability. Bladder dysfunction can occur due to congenital, acquired, or behavioral causes. These are few of the anatomical causes resulting into VUR. So posterior urethral valve is the most common anatomic obstruction of bladder. Other causes are Uretracele, diverticulum, Prunbelly syndrome, bladder extrophy. Functional causes, neurogenic bladder, which occurs in spina bifida and sacral agenesis. There is strong association between intravesical pressure more than 40 centimeter of water here. Other functional causes are neurogenic bladder, which is acquired due to abnormal voiding patterns in neurologically normal child, and bladder instability. So this is the grading of VUR, where the contrast flow into the ureter helps in determining different grades. So grade 1 is this is the first grade. Here, the contrast flows into non-dilated lower ureter. In the second grade, the contrast reaches up to the pelvis and calyces without causing any dilatation. The third grade is where there is mild to moderate dilatation of ureter, pelvis, and calyces with minimal blunting of fornices. The fourth one, there is we can see the blunting here, and there is dilatation of pelvis and calyces with mild tortuosity. The grade 5 has gross dilatation of ureter, tortuosity, and loss of papillary impression. Associated anomalies, Puget obstruction. In Puget obstruction, VUR is seen in 9 to 18%. Vice versa, in VUR patients, incidence of Puget obstruction is 0.75 to 3.6%. More common with higher grade of VUR. Other associated anomalies are complete duplication of ureter, where reflux occurs mostly into the lower pole. Bladder diverticular, renal anomalies, renal agenesis. Spontaneous resolution is seen in neonates and young children, and it occurs due to bladder and urethral growth. There is elongation of submucosal tunnel and changes in bladder dynamics. That is, the bladder increases in size, with resulting in lower intravesical pressures. Post-infectious scarring, VUR predisposes the kidney to ascending UTI. And it is said that the most severe renal injury occurs with first infection. The risk of scarring is greatest in patients below 1 year of age, and it is uncommon with children more than 5 years of age. What are the symptoms? The symptoms are mostly non-specific in neonates and infants, and one should suspect in any infant with unexplained fever more than 3 days. Infant and children may have symptoms of diarrhea, abdominal pain, vomiting, and poor weight gain. Older children have features of dysuria, urgency, frequency. palpable mass in flank, hematuria, bedwetting, and foul-smelling urine. As the children gets older, the complications of reflux nephropathy sets in, resulting in hypertension, renal failure, delayed renal growth. Important histories associated are history of constipation, dysfunctional voiding, toileting habits, drinking habits. Important physical signs that one should look in child with UTI. Features of raised blood pressure, palpable mass, palpable bladder, palatable kidney. Spinal defects has to be checked. External genitalia, labial adhesion, phimosis, signs of inflammation, abnormal urogenital confluence, epididymo-orchitis. Evaluation of urinary infection. Urine examination is important. Urine routine and urine culture. So urine culture and sensitivity is a gold standard for diagnosis of UTI. Urine should be processed as soon as possible after collection. Midstream clean catch urine is preferred. So the collection from bag results in a high false positive with contamination from skin and rectum. Suprapubic aspiration is the most sensitive. Who needs X-ray evaluation? Any child with febrile UTI or recurrent UTI, all females less than 5-year-old with UTI, non-febrile UTIs, and children who do not respond promptly to the therapy. So standard workup can include MCUs, ultrasounds, DMSAs. So top-down approach, it is mostly to determine the children. It is mostly used in children who are at risk of renal scarring. Initial evaluation should be kidney, including sonography to exclude surgical condition that predisposes to infection. DMSA renal scan is obtained following febrile UTI, and cystography is reserved only for patients with abnormal scintigraphy or recurrent UTIs. It has increased compliance and because it eliminates getting over treatment in clinically insignificant VUR, and VCUG VCUG can be avoided in about half of the patient with febrile UTIs. Children with a negative DMSA scan won't require any further evaluation. According to bottom-up evaluation, cystogram is done first to detect the presence of VUR, Retractile, PU valves, along with sonogram to look for obstruction, hydronephrosis, and other congenital malformation. So it is said that if DMSA scans are normal in case of higher grades of VUR, the follow-up had shown that there is resolution and downgrading of VUR, and no new renal scarring was seen in the follow-ups. Assessment is done with MCUs. Static films tells about the bladder contour, diverticula, uretrocele, grade of reflux, configuration and blunting of calyces, bladder neck anatomy, and urethral patency. Dynamic films tells about the active reflux. The delayed films are important because they document the clearance of contrast from upper tract, and they tell about any PUG obstructions or VUG obstruction, which can be determined by the retained contrast and dilated PCS. Nuclear cystography, it is ideal for screening, follow-up after any anti-reflux surgery. It also monitors helps in monitoring the natural history of disease. So greater sensitivity is seen in higher grades. Grade 1 reflux into distal ureter is poorly detected. Renal scans. DMSA is used to assess the pyelonephritis and cortical renal scars. It is 98% specific. Radio tracer is taken up by functional renal parenchyma. Time of evaluation. It is suggested that a delay of 4 to 6 weeks should follow after any acute infection and should be done when the urine is sterile to avoid any transient mild reflux secondary to inflammatory changes at UV junction. Also, it helps in document irreversible renal scarring After any episode of infections, the delay should be up to about 6 months. IVP is less commonly used. Renal ultrasound is useful in quantitative assessment of renal dimensions and to determine the degree of corticomedullary differentiation. Uroflowmetry and urodynamic study, they help only to know about the bladder emptying characteristics. In reflexing patients, uh, bladder outlet, it establishes whether bladder outlet is functioning relatively normal or has more resistive characteristics. Cystoscopy has limited role. It is indicated in cases where the radiography is unconclusive in defining the lower and upper tract. It identifies the location of ectopic ureters. It is indicated in cases of non-visualization of entire urethra on cystogram. It is also performed along with any planned surgical repair. So coming to the management, spontaneous resolution of reflux is common. Higher grade is less likely to resolve spontaneously. Watchful waiting means while maintaining urinary sterility through judicious use of single daily low dose antimicrobial prophylaxis. Night dose is preferred because it helps in allowing the antibiotic concentration in bladder uh, over the longest period. Breakthrough febrile UTIs or pyelonephritis while the patient is on antibiotic prophylaxis is considered as indication for termination of watchful waiting. Success rate of surgical with surgical correction is very high. One must address UTI risk factors first, which includes hydration, bowel management, toilet training, antibiotic prophylaxis. It should be started following first UTIs in all children less than 2 years. In children with VUR up to 5 years of age, when scars are seen on DMSA, in patients with frequent febrile UTIs, and in patients where imaging is awaited. Imaging results are awaited. However, antibiotic prophylaxis is not routinely advised in cases of patient undergoing CIC, urolithiasis, and neurogenic bladder. These are the recommendations for the antibiotics which can be used. Cephalexin is preferred in infancy, and these are the doses and durations of all the antibiotics that are advised. Surgical management. Absolute indication is breakthrough urinary tract infection, failure of medical management, persistent of reflux with prolonged medical management, and progressive deterioration in renal function or evidence of scarring. Refluxing ureter opening into bladder diverticulum or duplex kidney requires surgical management. Cystoscopic presence of golf hole orifice needs to be repaired surgically. Relative indications include girls whose reflux persists after they have reached the puberty and parauretral diverticulum. So all the grade 5 viewers need surgical correction. Options include open or vesicoscopic repair and intravesical or extravesical repairs. Submucosal injection, circumcision is done in selected cases. Techniques can be, these are the different techniques which are used. Principles of surgical correction. One should exclude all the secondary causes. Adequate ureteral mobilization without tension and is needed to protect the ureteral blood supply. One should prevent angulation and twisting of the ureter in the submucosal tract, and bladder tissue must be handled gently. Attention to muscular backing of ureter is important. The submucosal tunnel should be in the ratio of 5:1. That is the length and width that was recommended by Paquin. So Cohen's cross-trigonal intravesical repair is has a 96 to 99% success rate. It is useful for correction of VUR in thick and small or neuropathic bladder. So this is the vesicoscopic repair. First hysteroscopy is done. The ureteric orifice having VUR was dilated. Cannulation is done with 5 French infant feeding tube. 3 sutures are taken near the ureteric orifice. Dissection is done and dissection is done using scissors, and the ureteral lengthening is done using hook cautery. The same rule of Backwin is followed here also. The length to width of the ureter, the length of the tunnel is 4 times the width of the ureter. The opposite ureteric orifice is cannulated with the ureteric catheter. Submucosal tunnel is made with the help of scissors. And cross-trigonal ureteric reimplantation is performed here. The detrusor, the margins are freshened up, and the anastomosis is performed between the ureter and the bladder using 5-0 vital sutures. DJ stent is placed. The defect in detrusor is closed. This is the extravesical ureteric reimplantation. Cystoscopy is performed. We can see a large bladder diverticula on right side. Here the ports are placed, the camera port is placed in umbilicus, and 2 working ports are placed laterally. The diverticulum is dissected. A stay suture is placed, and this diverticulum is excised. The defect in the bladder is closed with interrupted sutures. Another opening, this is a dissection of the bladder diverticulum. The ureter is played laterally. DJ stent is placed between the ureter and bladder. Anastomosis is done using Vital 5-0 interrupted sutures. After the anastomosis is complete, a trough is made superiorly on the bladder wall, and the ureter is placed in this trough. The defect in the bladder is closed. The defect is being closed with vital sutures. So complications can be persistent reflux, contralateral reflux. However, prophylactic bilateral reimplantation for unilateral reflux is not recommended. Obstruction can occur due to edema, clot, or any kinking. PCN or stenting can be done here. Redo surgery may be required. So endoscopic management. Here, injection of a bulking agent is done in the intravesical portion of ureter in the submucosal plane. It elevates the intravesical ureter, causing narrowing of the lumen. It prevents the regurgitation of urine and allows antegrade flow. The advantages are less mobility. However, it is mostly performed in, it has lower success rate in higher grade of reflux. These are the agents used in endoscopic correction of VUR. Dextramer hyaluronic copolymer, that is Deflux, is most commonly used. So a Deflux needle is placed into the urethral submucosa at 6 o'clock. The initial injection lifts the floor of the urethral tunnel and coaptates the ureter, so causing the pinching of the ureteric orifice. Here we can see a 4 French metal needle can be used to a 6 French cystoscope. This metal needle is placed in the submucosal plane, and the agent reaches up to the lamina of the ureter, creating a volcano-like appearance. The end, so about 0.5 ml of the agent can be placed here, and one should wait up to 20 to 30 seconds after putting the needle and the agent. The end result is the slit-like appearance of the ureteric orifice and nipple formation. So patients are during follow-up, patients are given the uroprophylaxis. This can be discontinued on resolution of the MCU features. Patient has to be monitored for renal function, growth. Follow-up USG and urine culture can be done after 6 to 2 weeks. It is done monthly for first 3 months and thereafter every 2 to 3 months. MCU can be repeated after 3 months, DMSA after 1 year. To conclude, VUR requires watchful management and follow-up. Antibiotic has limited use, and the goal of therapy here is to prevent renal scarring and improve the quality of life. Deflux is safe and effective in grade 3 to 4. Vesicoscopic ureteric reimplantation is very successful in higher grades of VUR. Thank you.
Can you see the screen? Anyone there?
Yes, we can see.
I will reshare now. Can you see it?
Yeah, we can see.
Okay. Good afternoon, everyone. On behalf of SRCC Children's Hospital, once again, I thank you all for joining today. So I am going to speak on advanced minimal access pediatric surgery. We started about 26 years back doing advanced minimal access surgery in India. And our first surgery was pull-through for Hirschsprung's disease, which we had performed on 20th December 1998. And then that was the starting. And since then, we have been doing almost all kind of surgery using minimal access pediatric surgery. Is screen is moving? Hello? Anyone there?
Yes, sir, moving.
Okay. So, what is advanced surgery? So, surgery in infants, newborns, and young children, they fall into category of advanced surgery. In newborns, we do as today esophageal atresia as well as congenital diaphragmatic hernia, Hirschsprung's, duodenal atresia, and many more surgeries using minimal access pediatric surgery. Suturing of small structures like pyeloplasty, choledochal cyst, again, they are not easy operations to be performed using minimal access surgery, and all this will fall into advanced category. Dissection of major vessels, particularly in surgeries like lobectomy, splenectomy, they again are advanced surgery. Delicate surgeries like orchiopexy in undescended testes, pyloromyotomy, operating on sick kids, many times malrotation of bowel, they are quite sick. The advantage is many times converting multi-stage surgery into single stage, decreasing the morbidity, like in Hirschsprung disease. Thoracoscopic surgery, most of the thoracoscopic surgery will fall into this category. So, most of the surgeries in children falls into the category of minimal access pediatric surgery. But today we are just going to focus on minimal access thoracoscopic pediatric surgery. Just to tell you, we have been doing 3-day course at IMUS right now on thoracoscopic pediatric surgery. And that's why I said that might as well speak on just one sec. बिजी हूँ मास्टर क्लास में, बाद में फोन करता हूँ. Indications of minimal access thoracoscopic pediatric surgery includes empyema, where we do debridement and decortication. Biopsies, lung, lymph node, pleural biopsies, diaphragmatic hernia, posterior lateral, anterior lateral, anterior, all can be done using minimal access pediatric surgery. Eventration of diaphragm, which can be congenital or acquired following cardiac surgery. Cysts, mediastinal or lung, T fistulas in newborn, recurrent T fistulas, esophageal stenosis, lobectomy, sympathectomy, thymectomy, all this can be done using minimal access pediatric surgery. We will go through some of the slides. Now, for doing all these surgeries, it is very important that we know about bronchial anatomy. So, if just for information of those who are attending, there's the trachea, then it divides into right and left mainstem bronchus. The right mainstem bronchus is more straighter than the left, and the angle and the length of right mainstem bronchus is about 2.5 centimeter. This is about 2.5. That's the middle lobe comes from there, and then the lower lobe. Similarly, on the left side, left mainstem bronchus is about 5 centimeter long, which divides into upper and lower lobe. Upper will have lingular lobe as well. Now, it is important to know, because if you are going to perform all these surgeries, then your anatomy should be strong. Otherwise, it becomes difficult to do it, particularly in thorax. And selective ventilation is very important for performation of many thoracoscopic surgery. And this is done by anesthetists, and good pediatric anesthesia team are very important for doing advanced minimal access thoracoscopic pediatric surgery. That can be achieved using either double lumen tube, something like that, or use of Fogarty balloon, or easiest is using simple endotracheal tubes, which can be put on the opposite mainstem bronchus along with CO2 insufflation. And most of us will be using that. If you have flexible pediatric bronchoscope, it helps in achieving the selective ventilation. And fortunately, at SRCC, we do have flexible pediatric bronchoscope. The physiology of selective ventilation will not go into details of that. But one thing one has to remember when you are giving in a newborn, particularly CO2 insufflation, then the CO2 can rise and there can be hypoxemia. And in such a situation, we stop insufflation of CO2, allow lung to expand back, wait for a few minutes and restart the surgery. And most of the time, even the newborns will adjust to new physiology, whatever happens after the selective ventilation or one lung anesthesia. Again, as I told you, it is very important for us to know the anatomy. So it is, if you are not routinely doing thoracoscopic advanced surgeries, then it is better to brush up the anatomical understanding before getting into the surgery. So this is just for information that there are today a lot of softwares available, and we use some of them to, if required, to refresh our anatomy before starting such a surgery. A lot of YouTube videos are also available. Then one needs to know even the anatomy of diaphragm, particularly if you are going to do congenital diaphragmatic hernia thoracoscopically or anything similar if you are going to do. Then there are special equipments available. Some of them are very important. Some of them, if you don't have, you can still go ahead and do thoracoscopic pediatric surgery. Now, this is just for understanding. This is the endo loop. These are the short trocars which are available today, and they do not have even valve because they are not mandatory. Then if you see, there are curved instruments. These are available today, but it is difficult to work with some of them, and we continue doing our laparoscopic, thoracoscopic surgery, using regular instruments. We do not use anything of this. Then you have endopex. This hemlock clip, if you see, once you clip it, it gets locked, and they are very important and means good to use because they will not slip. And all these vessels and bronchus, they are very important. If they slip, these clips, then you can have torrential bleeding with the problems. This is hemlock clip, which you can, with roticulating one. We do not have this, but if you have, then it is definitely advantageous. Then this is bipolar vessel sealing device. Again, very important for doing thoracoscopic surgery. You can diathermize and control even vessels up to 7 millimeter using this vessel sealing device. And most of the smaller vessels, you can just buzz with this and you are fine. And the seal which you get is almost, it can withstand 3 times the systolic pressure. So bipolar vessel sealing device is very important for performing thoracoscopic surgery. Similarly, the staplers also helps in performing thoracoscopic pediatric surgery. Generally, we use vascular stapler, which are white color, which is 2.5 millimeter open length and 1 millimeter once it is closed. So something like this we use routinely when required. Ergonomics for even thoracoscopic surgery is very important. And this is what we tell every one of our students, that you need to fix the trocar with the skin so that lung does not expand on your telescope. Use of gravity, triangularization, is very important. Then always think site of lesion, distance from lesion before getting into port placement. So position of patient, port placement, everything is very important, and you need to have three-dimensional understanding. For information of viewers, like before we start the surgery, we think how we are going to do. So this was a neuroblastoma in a 10-month-old child, which is on left side, just above the diaphragm at the level of D11, D10, 11, 12. So this is the patient position, semi-prone position, and this is the location of the tumor. You mark it outside on the body. Then you plan your port incision, where you are going to put the ports. So all this you plan, and then you start the surgery. And in each and every patient, whether it is thoracoscopy or laparoscopy, we do this because this is very important to perform, particularly the conditions which are not routinely being done. So empyema is one of the surgery which we started performing quite early, even in India. And today, most of the empyemas are taken care by using endoscopic or minimal access pediatric surgery. Now, empyema goes through 3 stages: acute, subacute, and chronic. So what I am going to show is, this is like in acute stage. Yeah, sorry, the video. Okay. So in acute stage, which lasts 3 to 7 days, which overlaps with subacute stage, you have something like this. There is a fluffy fibrinopurulent material. If you get rid of this, then the kids do well. Their febrile period reduces significantly. They become afebrile anywhere between immediately after surgery to 3 days. And the drain will come out in 2 to 4 days, and most of the patients will be home by 6th day. If you don't do this, then they stay for very, very long. This is in subacute stage what you will see. The fibrinopurulent material becomes thicker and thicker and thicker, and it will not come out through the ICD. So if you put an ICD, it is futile. So if any patient who has history of more than 5 to 7 days, and on sonography, if you see the loculations, the best treatment today is doing thoracoscopy and getting rid of all this fibrinopurulent material under vision. So this is what we do routinely, and most of this patient will become afebrile either on the day of surgery or within 48 to 72 hours. And again, they will be discharged within 6 to 10 days most of the time. What we do is use curved open instruments like overloading forceps for the removal of all this material. And we could give suction irrigation to the chest cavity and get rid of all fibrinopurulent material. At the end of the procedure, what we are supposed to see is fissures are clear, diaphragmatic surface is clear, and anteriorly, posteriorly, all this fibrinopurulent material is out. If I think I am starting damaging the lung, then probably there's the time to stop. You'd get rid of most of the tough stuff, but not necessarily that everything has to be removed. And at the end, under vision, you will put either one ICD or two ICD, depending upon the condition of the patient. If there are a lot of significant air leak, I may put two, otherwise one is enough. And earlier we thought the chronic empyema, we may not be able to do it using minimal access surgical technique. But today I will say that if I can achieve space to work, I can get rid of any empyema, which includes even chronic empyema. So you can see that we could dissect between the lung surface and the pleural peel. You can see that that entire peel has been removed, which was quite fibrotic. And what the end result has to be, the lung expansion has to be achieved. If I can achieve good lung expansion, then I think I mean, that will be end of my procedure. If lung expansion is not achieved, then one may need to convert to open surgery and do it. For us today, empyema, most of us, I mean, most often will be treated using thoracoscopic surgery. If the rib space is not there, means there is no intercostal space, then I will do probably resection of the rib and open thoracotomy. Most of other cases can be managed using thoracoscopy. Sometimes there is a bad lung necrosis. So in such a situation, if it is localized, we may do debridement. If it is, and that can be maybe done thoracoscopically, but one has to be aware there can be significant bleeding, and one has to keep the blood ready and always be prepared for open conversion. Open conversion is not a complication. That is for the safety of the patients. And if needed, we don't think twice. Anytime, any surgery, you convert to open. If the necrosis is very bad, and if more than, I mean, if it is the entire lobe is involved or major part of the lobe is involved, we probably will go in and do open lobectomy. It takes time, but at the end, the patient, they do well. So that is about lung necrosis. This one of the second indication is lung biopsy, though not very common. It can be performed. There are two ways it can be done. One is using stapler and second is using endoloop. Usually we perform on the right side. If it is bilateral infiltrative disease, then any side you can do it. Right side we prefer because there are two fissures, and because of that, there are more angles from where I can do biopsy. Now, this is for bilateral infiltrative disease. If there is localized nodules, then depending on the site of the nodule, one can biopsy. Now, what we'll be showing you is one of the patient where we did stapler biopsy. You can see multiple nodules are there. So we will put the stapler. Now, unfortunately, we do not have smaller size of staples in India. So we use the large adult size of the stapler, which is 12 millimeter in diameter. So this is 12 millimeter in diameter stapler. After applying the staple, you wait for 30 seconds and then you fire the staple line and then cut the stapler. I mean, it will cut, and then that part of the lung will be sent for all investigations, which includes culture, etc., histopathology. That is a stapler biopsy. The second I told you is using a endoloop. So that can also be done. And at the end, we put an ICD, which generally is removed after 24 hours, and the patient can be discharged home. Then generally we put all this staple from anterior surface because the rib space is larger, intercostal space is larger over there. The diaphragmatic hernia is again one of the good indication to perform it thoracoscopically. I'll show you the video. This was in a newborn. There is no mesh. We are doing thoracoscopic repair. What you can see is small bowel, large bowel, spleen, all that you will see as the content, and that you slowly, steadily reduce with using this 3 millimeter bowel grasper. And then that's the edge of the diaphragm, and which I have to make it free from the underlying structure so that I can put the suture. This is 2-0 ethibond suture which is being placed. We are achieving this repair by using CO2. CO2 insufflation is being done at low pressure and low flow. Low pressure is 5 centimeter of water and flow is 0.5 liter per minute. Once you put the first suture in, then the bowel it will stay in abdomen, and then you can continue the rest of your repair. So we are just closing that now, suturing that. And what we use is a tumble knot or sliding knot. And that allows us to suture even when the tissues are under tension. So that is being done. So even in newborn, you can do thoracoscopic repair for diaphragmatic hernia. So once suture is done, then we are continuing on lateral side. As you go laterally, it becomes little difficult. So you need to do release of the diaphragm from both the sides. So that second suture is being placed. Then you put the rest, and the last suture we'll put, which what we call is a transcostal suture. So the suture comes from outside, the knots are tied outside in subacute along with the rib. So the lateral most suture is usually difficult, and we do transcostal suturing. The results are very gratifying. So that is, both the sutures will be going out and you will tie in a subacute place. You put an ICD and come out. You remove the ICD whenever it stops draining, which is usually 2 to 4 days. These are some more videos. I'll show you one more video and then we'll go to the next. Yeah. So this is with sac, this hernial sac, this diaphragm. Now, when we started, we thought it is a very large defect. We may not be able to close. So we release the diaphragmatic attachment, that is esophagus. Behind that will be the aorta. And then we decided to put first suture and then decide whether it will come or not. But fortunately, as we started suturing, we could get both the edges together. So that is again 2-0 ethibond sutures, which is in place. We will be using sliding knot technique. That's the lateral aspect, that's the medial aspect. And you can see nicely it has been sutured. You close the medial side, this side is no problem. You can just put multiple sutures. The laterally, absolute, the lateral part, you release it from the attachment, from the chest wall, and then put the suture, and last suture we will put transcostal, like what I showed you earlier. So this transcostal suture will be placed using loop suture, using regular needle or epidural needle. So that is being done. That end of the thread will be pulled out using loop suture, and the knot is tied in subacute. You allow the diaphragm to rise at this point. One more small video which will show you. This is again in a newborn. Now, what you do is, first is assessment, whether you can bring it together or not. So this is in a newborn, we are seeing that is the anterior lateral defect. Now in that, the part of the defect will be sutured muscle to muscle, and the rest will be with the anteriorly with the ribs. So I am going to jump it. Yeah, so you can see this is the anterior muscle closure is done, and the lateral part will be done to suturing with the ribs. So these are all sutures anteriorly taken with the rib. And some of these sutures will be tied in the subacute area. So this is the diaphragmatic hernia. The results are very gratifying and good. So this is how you decide about the port insertion. We will go further down. Even the more anterior or Morgagni hernia, we use minimal access surgical technique, but we do it using laparoscopy. The first laparoscopic Morgagni hernia repair, we did it in 1999 using our innovative approach. But today, as I am speaking on thoracoscopic surgery, I am going to skip that. The second, one of the common condition is T fistula with esophageal atresia in a newborn child, and that can be also managed using laparoscopic surgical technique. Yeah, so what we are seeing here is, can you hear me, no? I think yes. So, what we are doing is dissecting the fistula, that's the esophagus, lower pouch, which is not joining the upper pouch. That is a vagus now. This is in a newborn, we are doing esophageal atresia with T fistula. That is the upper pouch, which is blind, and lower pouch is a fistula with the trachea. So there is a communication between trachea and esophagus. Then we have put a suture to elevate the lower pouch of the esophagus so that we can dissect the communication from the trachea and transfix that. So that is the transfixation which is being done using 5-0 PDS suture. We'll transfix that, then divide it, spatulate that, and then we'll do the anastomosis between upper pouch and lower pouch. The results of this surgery are quite good, and many people across the world have started doing T fistula using minimal access surgical technique. the results are equivalent. There are some advantages of doing it thoracoscopically. I think we will see that in the next slide. So this has been divided. The fistula has been divided. Then the upper pouch will be spatulated. That is being spatulated. Spatulation is being done. Then we will dissect the upper pouch. So stay is taken on the upper pouch. It will be dissected. And then the incision will be made. The incision has been made that both the pouch has been, upper and lower pouch has been sutured together. Then the anastomosis will be done. So then we are doing the anastomosis. At the end, we will put an ICD and come out. After 5 days, we do dye study, contrast study. Make sure the pouch has healed well and there is no leakage. And then you start the oral feed. There is a transanastomotic tube through which we will start feeding on day 1 or day 2, and then make it oral once everything is confirmed that it has healed well. So today T fistula also can be done using minimal access surgical technique. So that is the anastomosis being completed using 50 PDS suture. The advantage of doing it using minimal invasive technique, or what is the difference between the two? Thoracoscopic is transpleural. This is usually extrapleural thoracotomy. Longer operating time. Thoracotomy is shorter operative time. Again, longer operative time is the initial phase. Once the team knows how to do it, probably the time will be equivalent or even less. There is a better visualization, particularly of the fistula, and you control the fistula first so that the ventilation is achieved much faster as compared to the open surgery. And you can completely avoid the musculoskeletal problem like what you can see in this particular child. Of course, this is one of the very bad scar. You don't have even in open so bad scar in most of the patient, but you can avoid whatever deformity, musculoskeletal deformity when you use minimal access surgical technique. So advantages includes avoidance of musculoskeletal sequelae, superior visualization of anatomy, and easy to identify fistula or ligation. Now I'll tell you about lobectomy. I'll just show you one video because it's already 5 o'clock. And then we will call it a day. So this is right upper lobectomy in a 9-year-old girl, which is done completely endoscopically. So you can see there is a large cyst in the right upper lobe. These are the places where we have inserted the port. This is for ergonomics for those who are interested. This is the position of the patient. And then we have put the first port, camera port. You can see beautifully the fissure. You can see entire anatomy of the chest so well. That's the phrenic nerve with superior vena cava over here. You can see pulmonary vessels. You will see azygous vein. That's the horizontal fissure between upper and middle lobe. That is oblique fissure down. So anatomy is beautifully, one can see that is internal memory. Sorry. So this is in an older child where there is a one lung ventilation is being given. We are doing just the assessment, how the things are and how we are going to do. First step is completion of the fissure so that you have a good exposure. Then you dissect out the vessels. Pulmonary vessels are being dissected. We'll have pulmonary artery and pulmonary vein, and then the bronchus and bronchial vessels to be taken care of. So step by step, the dissection will be done. The beautiful instrument, what you see is a bipolar vessel sealing device, and it can control the vessels up to 7 millimeter in size. So this is a boon for those who are doing minimal access surgical technique today. Even in open, we use same or similar instrument, which are hand instrument. This is for laparoscopy with a longer blade. So that dissection is being done. This is just, we are trying to understand how the things are. And then you can see that's the pulmonary artery which is being dissected. The azygous vein you can see going across over there. That's the azygous vein. That is superior vena cava with the phrenic nerve over there. The vessel loop is placed so that we can clean. Yeah, that is azygous vein, superior pulmonary artery, phrenic nerve going right there, right upper lobe, sympathetic trunk. And these are hemlock clips. They are very sturdy. Once you apply it, it will not slip. So we will apply 3 of them and then divide it. And these are the pulmonary veins which are being dissected. Once they are dissected, even on that, we'll apply the clip. And then this is pulmonary vein. The artery has been clipped and divided. There's one vein. The rest of the veins are being dissected. So this is the more veins are being dissected. Superior pulmonary vein. So again, after dissection of the vein, we'll clip it. So that hemlock clips are being placed. First one was on both together because they were joining, and then single, and then you use ligature. And this is bronchial vessel, again quite large, and one has to be careful. So we will control that and then divide it. The last part is the bronchus. So that's the bronchus where we are applying this hemlock clip, and then we will divide it. So 1, 2, and then the division. So then it has been divided. And the air and some blood from the divided specimen side will come. At the end, we will give good wash and come out. So today, even many lobectomies can be done using minimal access surgical technique, and the patient should be given the choice for the same. I think I will stop over here. If there are any questions or queries, I will be happy to answer. Similarly, any one of my colleagues, if you have any questions for our colleagues also, you are most welcome to ask that. Any questions from anyone? Again, on behalf of SRCC Children's Hospital, I thank you all for joining today's masterclass, which was update in pediatric surgery. So thank you all. I think, as you know, that this masterclass was started in January 2019. It has completed almost 6 years. This is December, so 6 years are over. Next year will be the 7th year will be starting. It is on the 3rd Wednesday. Earlier it was physical, and since COVID time, it was converted into online masterclass almost immediately once the COVID started. So only gap of April and May 20 we did not had. So next masterclass will be on 3rd Wednesday of January, whatever is the date. It will be from 2:30, and our pulmonologist will be participating in that masterclass. The agenda will be planned and will be sent to you all over the next few days. Once again, thank you all. And as you know that it is MMC points, so by attending the masterclass, you will be given even points, CME points from the Maharashtra Medical Council. Thank you one and all. Manmohan or Rujul, whoever is around, you can call it a day. Thank you, everybody.